Defibrillation vest for patients after a heart attack. Temporary protection against heart attack. In the light of the latest research and guidelines, incidents related to the acute phase of infarction, before obtaining a reliable assessment of the degree of heart damage, do not qualify for the automatic use of implantable devices in such patients. At the same time, if a patient reacts to a heart attack with sudden cardiac arrest, SCA, or an arrhythmia such as ventricular tachycardia or ventricular fibrillation, it is necessary to protect the patient because the risk of sudden cardiac death, SCA, is high. Professor talks about the current possibilities of temporarily protecting patients after a heart attack against NZS using a defibrillating vest. Robert J. Gill, head of the cardiology clinic at the State Medical Institute of MSWiA in Warsaw, president of the Polish Society of Cardiology. Sudden cardiac death may occur peri-infarction, i.e. in the acute phase of myocardial infarction, but it may also be its manifestation and first symptom. It may also be a consequence of a heart attack, especially in the first 3 months after the incident. Myocardial infarction is caused by acute ischemia of an area of the heart muscle due to occlusion of a coronary artery. This often leads to necrosis and damage to the structure and function of the heart. Coronary heart disease, which may result in a heart attack, is associated with the deposition of atherosclerotic plaques in the coronary vessels, which impede blood flow, which may also lead to myocardial ischemia. Both the acute ischemic event itself and the healing of the pericardium constitute a situation in which life-threatening ventricular arrhythmias are more likely to occur and may lead to sudden cardiac death. Urgent revascularization of the coronary vessel, i.e. restoring blood flow, gives a chance to save as much of the myocardium as possible from necrosis. The faster the procedure is performed, the better the treatment effect. The initially significantly damaged systolic function of the heart often improves after appropriate treatment. This reduces the risk of sudden cardiac death. However, this is not a several-day process and requires longer observation of the patient, emphasizes Professor Robert J. Gill. In the light of the latest research and guidelines, incidents related to the acute phase of infarction, before obtaining a reliable assessment of the degree of heart damage, do not qualify for the immediate use of an implantable device in such patients. On the other hand, if a patient with a heart attack reacts with sudden cardiac arrest, SCA, or an arrhythmia such as ventricular tachycardia or ventricular fibrillation, the risk of cardiac arrest is high, which necessitates the need to protect the patient against it. According to specialists, risk assessment can be really difficult, but there are currently available methods of temporarily protecting patients against sudden cardiac death, which allow for temporary and reversible protection of patients against cardiac arrest, without the need to make radical therapeutic decisions about the implantation of a permanent high-energy system, the so-called cardioverter, defibrillator. This solution is justified to be considered in the case of patients in whom there are no clear indications for ICD implantation, or the risk of sudden cardiac arrest leading to sudden cardiac death may be transient. In such cases, there is space to protect the patient with a defibrillation vest, which is able to detect a life-threatening arrhythmia and interrupt it, thus saving the patient's life, says Professor Robert J. Gill. The Service of Temporary Protection of Patients Diagnosed with an Increased Risk of HF with the use of a defibrillating vest, also in the group of people after a heart attack, has been available in Poland since 2020. The WCD device takes the form of an elastic vest worn by the patient directly on the body. It is an external diagnostic and therapeutic system, which consists of a set of 3 defibrillation electrodes and 4 ECG electrodes and a monitor managing their operation. An additional element of the WCD system is a modem, with a charger, for data transmission and telemonitoring. If rapid, life-threatening ventricular arrhythmias are detected, the device alerts the patient and, if the patient fails to respond to delay therapy, warns bystanders not to touch the patient. The system then automatically delivers high-energy therapy to interrupt the arrhythmia. Unlike implantable devices, in the case of a defibrillation vest, the patient has the option of delaying therapy if the detected arrhythmia is tolerated and the patient remains conscious. This is intended to reduce the number of painful, inappropriate discharges, especially in the phase of dynamic changes in the infarction area, where all new patient parameters, such as the tolerance of a fast heart rate, are not yet confirmed. WCD does not require permanent implantation and does not expose the patient to the potential risk of complications related to the procedure and use of the device. Moreover, after the indications for protection have ceased, the patient can simply remove the device after the doctor's decision. The defibrillation vest combines elements of an ECG monitor, a fully automatic external defibrillator and an online system for remote monitoring of the patient and the technical condition of the device. Indications for the use of WCD technology are included in the guidelines of the European Society of Cardiology, ESC, and the American Heart Association, AHA. In Poland, an opinion was issued by the Heart Rhythm section of the Polish Society of Cardiology, which was based mainly on the results of the VEST clinical trial, conducted, among others, in Polish centers among patients after a heart attack. The results of the VEST study and the per-protocol analysis indicate statistically significant benefits resulting from the correct use of the device. Olganja, Lee B.K., Vittinghoff et al. Impact of wearable cardioverter defibrillator compliance on outcomes in the VEST trial, as treated and per-protocol analyses. J. Cardiovascular Electrophysiol 2020, 31 to 1009-18. The defibrillation vest protects the patient immediately after putting it on and configuring it, and remote monitoring can begin immediately after the system is connected to a secured online system. This may result in an intuitive desire to discharge the patient immediately after being secured, which may shorten the patient's hospitalization time and increase the availability of beds in cardiology wards and clinics. This is confirmed by reports and registers such as, wearable cardioverter defibrillator shortens the lengths of stay in patients with left ventricular dysfunction after myocardial infarction. A single-center real-world experience, Laura Sophia Cardelli, J. Clin. Med. 2023, 12, 4884. According to experts, current Polish experience with protecting patients against sudden cardiac death using a defibrillating vest indicates that WCD is a method characterized by high cost-effectiveness. The technology is available and can be used not only in specialized clinical centers, but also in smaller local centers that are closer to the patient. It can be expected that the introduction of WCD into the basket of guaranteed benefits, including the definition of the rules of its use, will contribute not only to improving the standard of cardiological care in Poland, but also to a significant reduction in costs related to unnecessary implantation of high-energy devices and extending the duration of hospitalization. It is also worth paying special attention to the rapidly growing group of patients after surgery for structural defects, with particular emphasis on patients after implantation of a left ventricular assist device, LVAD, where there is no greater experience in this area and a huge investment in the patient is incurred, both financial and, as well as time. After such a procedure, the patient often goes out into the proverbial street without protection against cardiac arrest. Notes Professor Robert J. Gill. Currently, an administrative process is underway, the aim of which is to systematically include the provision of care using a defibrillating vest for selected groups of patients as part of the guaranteed benefits package. Currently, this is done as part of the individual consents of the payer, considered each time after securing the patient. It is important that patients who require temporary protection against sudden cardiac death can actually benefit from the protection using a defibrillation vest. Reimbursement criteria should be formulated in a balanced way, but not too narrow. It is worth paying attention to those groups of patients who may benefit the most in the form of lives saved or the lack of an implanted device, and there are no clear results of clinical trials yet. Often, clinicians would like to be able to use such temporary protection in cases where they need time for extended diagnostics and confirmation of indications for permanent protection. We are talking about patients with myocarditis or newly diagnosed heart failure or genetic etiology. Such a prudent approach is indicated by the experience gained so far from leading Polish clinics, where many such patients have been treated in recent years, and several of them are still alive thanks to this. The Polish Society of Cardiology hopes that the process will end successfully and patients requiring this form of care will have open access to this health service, sums up Professor Robert J. Gill. The orangutan healed the wound with a self-prepared herbal treatment. In Indonesia, a male orangutan living in the wild was observed preparing medicine for his wound from chewed leaves and stems. The plant used by the monkey has been used by local people for generations and is known to have anti-inflammatory and analgesic properties. For the first time, a wild Sumatran orangutan was observed chewing the leaves and stems of the akar kuning plant, Fibroria tinctoria, and applying the prepared paste to a wound on its cheek. This plant is known to have anti-inflammatory properties and relieve pain. The orangutan prepared the medicine for 7 minutes until it completely covered the wound with the paste, which clearly indicated that it was intentional. The monkey then chewed the plant's leaves for another half hour. Further observations showed that the wound had healed and no infection had occurred. An article describing the observations was published in the journal, Scientific Reports. Scientists from the Max Planck Institute of Animal Behavior in Germany and Universitas Nasional in the Gunung Leuser National Park in Indonesia observed a male Sumatran orangutan, Pongo abeli, that suffered a wound on its face, probably as a result of a fight with another individual. He ate and repeatedly applied akar kuning juice to the wound, a plant with anti-inflammatory and pain-relieving properties that the local population has been using for generations. He also covered the entire wound with a paste made from the chewed plant. This is the first documented case of a monkey using a plant with scientifically proven properties to treat a fresh wound. Scientists have been observing orangutans in an Indonesian park for many years. The area is a protected area of rainforest that is home to approximately 150 critically endangered Sumatran orangutans. The individual who demonstrated medical abilities first appeared in the monitored area in 2009 and was named Rakus. Similar behavior is rarely observed in animals. Some monkeys have been known to eat certain plants to treat parasitic infections and rub the plant material on their skin to relieve muscle pain or skin conditions. 2 years ago, a group of chimpanzees in Gabon were observed catching small insects, chewing them and applying them to their wounds. However, the effectiveness of this solution is still unknown. During daily observations of orangutans, we noticed that a male named Rakus suffered a facial wound, most likely during a fight with another male, says Isabel Laumer, first author of the study. 3 days after the injury, Rakus selectively detached the leaves of the akar kuning vine, chewed them, and then repeatedly applied the resulting juice precisely to the facial wound for several minutes. Finally, he completely covered the wound with chewed leaves. This and related species of the plant, which can be found in the tropical forests of Southeast Asia, are known for their analgesic and antipyretic effects and are used in traditional medicine to treat various diseases, such as malaria, Laumer points out, adding that chemical analyzers have shown the presence of compounds in the plant that are known to have antibacterial, anti-inflammatory, antifungal, antioxidant and other biological activities important for wound healing. Observations in the following days showed no signs of wound infection. After 5 days, the wound was completely closed. After a month, there was barely a visible trace left. Interestingly, Rakus rested more than usual when he was injured. Sleep has a positive effect on wound healing because the release of growth hormone, protein synthesis and cell division increases during sleep, explains Laumer. This case and others like it raise questions about the extent to which these behaviors are intentional and how they occur. Orangutans can learn from each other, and scientists speculate that Rakus's behavior may be a result of knowledge acquired from other monkeys. Rakus's behavior seemed intentional, as he selectively treated the wound on his right cheek with the plant sap rather than other parts of his body. This behavior was also repeated several times, not only with plant sap, but also later with more solid plant material, until the wound was completely covered. The whole process took a lot of time, Laumer says. Orangutans in this area rarely eat this plant. However, individuals may accidentally touch their wounds while feeding on this plant and thus inadvertently apply the plant's sap to their wounds. Because Fibroria tinctoria has a strong analgesic effect, individuals may experience immediate pain relief, says Caroline Shoeplay, co-author of the study, suggesting how the monkey could have learned about the plant's properties. Because this behavior has not been observed previously, it is possible that wound healing with Fibroria tinctoria has previously been absent from the behavioral repertoire of this orangutan population. Like all adult monkeys in the area, Rakus was not born in the park and his origins are unknown. Male orangutans move long distances from their birthplace during or shortly after puberty to either establish a new habitat in another area or move between each other's home ranges. Therefore, it is possible that more individuals in its native population, outside the study area, will exhibit this behavior, explains Shoeplay. The first mention of the treatment of human wounds most likely appeared in a medical manuscript dated to 2200 BC, and included cleaning, dressing and bandaging with specific wound care substances. Says Shoeplay, since forms of active wound healing apply not only to humans but can also be found in great apes in both Africa and Asia, it is possible that there is a common mechanism for recognizing and applying substances with medical or functional properties to wounds, and that our last common the ancestor had already demonstrated similar forms of behavior. He adds,